If you exercise every day, eat clean, take your supplements, and feel completely fine, what I'm about to tell you may save your life, and I need you to hear it before this week ends. There is a hidden electrical problem in the heart called atrial fibrillation, AFib for short. It affects roughly 1 in 11 adults over the age of 65. It quintuples your risk of stroke. And here is what almost nobody tells you. 1 in 3 people who have an AFib-related stroke had no idea they had AFib in the first place. They felt fine. They were healthy. They were active. They went to bed normal one night, and they woke up the next morning, unable to speak or unable to move one side of their body. Most doctors will tell you that if you exercise and eat well, your heart is fine. They will take your pulse for 15 seconds at your annual physical. They will write down regular on the chart, and they will completely miss what is actually happening inside your chest. So in the next few minutes, I'm going to show you the exact pattern cardiologists are now trained to recognize. The simple test you can do tonight, in your own bed, with nothing but 2 fingers and a clock. The one specific question your doctor is not asking you, and the 3 warning signs that fit healthy seniors miss almost every single time. Don't skip ahead. The 3rd sign is the one I really want you to hear. That is the one that catches fit people off guard. For the last 20 years, the cultural belief has been simple. If you exercise, you are protected. If you eat well, your heart is safe. If your blood pressure is normal and your cholesterol looks good, you have nothing to worry about. I want you to listen to me very carefully. That belief is wrong, and it is killing fit seniors every single day in this country. Here is what the research actually shows. Long-term endurance exercise, running, cycling, marathon training, does not just strengthen your heart. It also remodels the electrical system inside it. The same heart you have spent 30 years training to be strong has also been quietly reshaping its own wiring. And in some seniors, that wiring becomes unstable. The atria, the top 2 chambers of your heart, start firing on their own, randomly, chaotically, hundreds of times per minute. That is atrial fibrillation, and the people most likely to develop it are not the couch potatoes. They are the lifelong athletes. Let me show you what a typical doctor visit looks like. You sit down in the exam room. The doctor has 11 minutes. They ask, "Any concerns today?" You mention that you've been feeling a few flutters in your chest, maybe some lightheadedness when you stand up. Nothing major. The doctor takes your pulse. They count for 15 seconds, maybe 30 if you're lucky. Now here is the part that I want you to really sit with for a moment. The clot that forms in the heart is not a small clot. They do an ECG. The ECG shows nothing because at that exact moment, your heart is in normal rhythm. They smile, tell you you're in great shape, and send you home. Nothing is wrong with that doctor. They followed the standard of care. The problem is the standard of care. Because atrial fibrillation is paroxysmal, that means it comes and goes. It can fire for 30 seconds and then stop. It can run for an hour at 3 in the morning while you're asleep, and you will never know. It can hit you for 10 minutes after a strong cup of coffee and resolve before you finish the cup. The full minute. What you are listening for is not the rate, it is the rhythm. The other 86,000 seconds in the day go unobserved, and that is where AFib lives. By the end of this video, you will know more about catching this condition than 90% of family doctors. That is not an exaggeration. That is the gap that exists in routine medicine right now. Now let me explain what is actually happening inside your heart when AFib strikes. I'm going to use 2 simple pictures. If you remember nothing else from this video, remember these 2. Picture number 1. An orchestra. Your heart has 4 chambers and 1 conductor. The conductor is a small group of cells called the SA node. When the conductor is in charge, every section of the orchestra plays in time. The atria, the top 2 chambers, contract first. The ventricles, the bottom 2 chambers, follow a fraction of a second later. Blood moves smoothly to the brain. That is what a normal heartbeat looks like. Steady, coordinated, predictable. Now imagine the conductor walks off the stage. The orchestra keeps playing. But every musician is now playing whatever they want. The first violin is playing fast. The second violin is playing slow. The percussion is firing randomly. The result is noise, not music. That is atrial fibrillation. The atria are firing 300 to 600 chaotic signals every minute. The ventricles fire irregularly, sometimes fast, sometimes slow, sometimes with a long pause between beats. There is no rhythm. There is only chaos. Picture number 2. a clogged drain. When the atria are quivering instead of contracting, blood does not get pushed cleanly into the lower chambers. It pools, it swirls. And there is a small pocket on the side of the left atrium called the left atrial appendage. It looks like a little finger sticking off the side of the heart. Most of the time, it does nothing. But when blood pools in there during AFib, it starts to clot. That clot is small at first, then it gets bigger. Then one day, the clot breaks loose. It travels up the carotid artery, it enters the brain, and it lodges in a vessel that is too small for it to pass through. The blood flow stops. The brain cells downstream begin to die. That is a stroke. I need you to hear this clearly. AFib does not kill you directly. AFib creates the clot that kills you. Your heart can fibrillate for years, and you can survive it. But you cannot always survive the stroke that AFib causes. And that is why we are talking about it today. Now here is the part that I want you to really sit with for a moment. The clot that forms in the heart is not a small clot. It is not the kind of clot that causes a mini stroke that resolves in an hour. The clots that form in the heart are large. They travel as a single, dense piece. And when they reach the brain, they often lodge in one of the major arteries, the middle cerebral artery, the anterior cerebral artery, and they cause what cardiologists call a major embolic stroke. These are the strokes that leave people unable to speak, unable to swallow, unable to use one side of the body. These are the strokes that send a fit, healthy 70-year-old to a nursing home in a single afternoon. That is what is at stake. Not a small inconvenience, not a temporary scare, a complete reorganization of your remaining life. In the time it takes one clot to travel from your heart to your brain, about 4 seconds. Here is the part that is hardest for fit seniors to accept. AFib can be completely silent. No flutter, no racing heart, no symptoms at all. And silent AFib carries the same stroke risk as the AFib that hits you with obvious palpitations. The body can adapt to chaos. The damage continues anyway. There are documented cases of seniors who had been in chronic AFib for over a year with no awareness, diagnosed only after their stroke. The atria were quivering 24 hours a day. The clot was forming the entire time. They felt fine, right up until the moment they didn't. Now, here are the 3 patterns cardiologists are now trained to recognize. I want you to listen to all 3. The third one is the one I promised you at the start. Pattern number 1. Brief episodes of flutter or skipped beats that come and go, lasting seconds to minutes, most often felt while sitting still, lying down at night. The feeling is hard to describe at first. Some people say it feels like a fish flipping in their chest. Others describe it as a hiccup in the rhythm. Others feel a quick burst of speed, then a pause, then a return to normal. Most fit seniors blame caffeine. They blame stress. They blame a bad night of sleep. They tell themselves it's nothing. They never mention it to their doctor, and if it happens again next month, they dismiss it again. That is signal 1. If you have felt this even once in the last 6 months, mark it down. Pattern number 2. Sudden, disproportionate fatigue after a stable activity. You walk the same route you have walked for 10 years, and today, halfway through, you needed to sit down. No reason, no explanation. You weren't sick. You weren't underslept. You just suddenly couldn't continue. What happened in that moment is that your atria stopped contracting properly for a few minutes. The ventricles couldn't fill efficiently. The amount of blood reaching your brain dropped by 20 or 30%. Your fitness could not compensate, because no amount of fitness compensates for an electrical problem. Your engine is fine. Your spark plugs are misfiring. That is signal 2. Pattern number 3, the one fit seniors miss almost every single time. Brief lightheadedness when you stand up, especially the morning after exercise. Not full dizziness, not blackout, not the spinning room. Just a half second of the room shifted slightly before everything normalizes. You shake it off. You take a breath. You move on with your day. You may not even consciously notice it. Fit seniors blame this on dehydration. They blame it on low blood pressure. They blame it on getting out of bed too fast. They blame it on getting older. It is none of those things. It is your brain experiencing a drop in cerebral blood flow because your heart skipped a coordinated beat at exactly the moment you needed maximum cardiac output. The body recovers in 3 seconds. The fibrillating heart resumes a normal rhythm. The lightheadedness fades, and you forget about it. But it happened, and it is happening more often than you realize. The morning after a hard workout is when AFib is most likely to fire. When your heart is recovering, and your hydration is slightly off, and your nervous system is in a particular state, is when AFib is most likely to fire in active seniors. That is why this third pattern is the most important one for the fit audience. Let me give you a composite picture of what this looks like in real life. A 68-year-old man, active, hikes every weekend, maintains his weight, eats well. He notices over the course of about 4 months that he sometimes feels a flutter in his chest after his morning coffee. He blames the coffee. He cuts back on caffeine. The flutter eases for a while, then returns. He notices that on his Sunday hikes, he sometimes has to sit on a rock halfway up a hill. He blames the heat. He blames the season. He notices on 3 separate mornings after a long hike the day before, a half-second of the room shifted when he stood up from the breakfast table. He shrugs it off. He drinks more water. He moves on. 4 months go by. Then one morning, he doesn't wake up the same person. That story plays out somewhere in this country every single day. The signs were all there. They were all dismissed. The man was fit. The man was healthy. The man was not paying attention to what his heart was actually telling him. I am telling you this because I do not want that to be your story. The signs are different from a heart attack. The signs are quiet. The signs are easy to dismiss. But they are signs. If you have all 3 of these patterns, you are not in the early stage anymore. You are in the stage where this video found you in time, and that is a very good thing. I promised you something you can do tonight. Here it is. 3 simple tests. You don't need a doctor. You don't need a hospital. You don't need any equipment beyond your own 2 fingers and a clock with a second hand. Test 1. The 60-second pulse check. Most doctors take your pulse for 15 seconds and multiply by 4. That is acceptable for measuring your heart rate. It is completely useless for catching AFib, because AFib is not a rate problem. AFib is a rhythm problem. So here is what I want you to do. Find your radial pulse. That is on the inner wrist, on the thumb side, just below the bone. Place 2 fingers directly on it. Press gently. You should feel a clear, steady tap. Now look at a clock. Count for a full 60 seconds. Not 15, not 30, the full minute. What you are listening for is not the rate, it is the rhythm. A normal heart goes tap, 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 tap. Steady, even, predictable. An AFib heart goes tap, tap, pause, tap, 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 pause, tap. Irregular gaps, extra beats. Even one irregular gap during your 60-second count is a flag. Do this 3 times a day for 1 week. The single best time is first thing in the morning, before you get out of bed, because that is when paroxysmal AFib is most likely to be still firing from the night. Write down anything irregular, date it, time it, note what you are doing. Test 2. The standing test. Lie down on your back for 5 minutes. Stay calm. Take your pulse for 60 seconds. Write the number down. Now stand up. Wait 60 seconds standing still. Take your pulse again for 60 seconds. Write that number down too. A normal heart adjusts smoothly. The standing pulse may be 10 to 15 beats higher than the lying pulse, but it is still rhythmic. An AFib heart often produces a wildly different second reading. Sometimes 30 beats higher. Sometimes irregular. Sometimes the rhythm changes entirely between the 2 readings. That difference is diagnostic. Bring those numbers to your doctor. Test 3. The smartwatch ECG. If you own an Apple Watch, a Fitbit Sense, a Samsung Galaxy Watch, or a small device called a Kardia Mobile that costs about $99 at any pharmacy, you have a clinical-grade ECG in your pocket. Use it. Take a reading anytime you feel a flutter. Take a reading randomly during the day for 1 week. Take a reading first thing in the morning. Save anything flagged as irregular rhythm. Bring the printed strips to your doctor. They cannot dismiss a printed ECG. They cannot say, it must have been nothing. The strip is data. The strip is evidence. It gets you to the right diagnosis without a 6-month wait. If you score positive on 2 out of these 3 tests, call your doctor this week. Not next month, not at your annual physical, this week. And when you sit down, I want you to use this exact phrase. I want a 30-day ambulatory ECG monitor, not a 24-hour Holter. That sentence will change the entire visit, because it tells your doctor that you understand the difference. And no doctor wants to look like they were going to order the lesser test. Now I want to give you something even more powerful. something most fit seniors never know to ask for, something your cardiologist may not even volunteer at your first visit. Most cardiology workups for skipped beats follow a predictable pattern. They do an in-office ECG. Maybe they order a 24-hour Holter monitor, something your cardiologist may not even volunteer at your first visit. Most cardiology workups for skipped beats follow a predictable pattern. They do an in-office ECG. Maybe they order a 24-hour Holter monitor. That entire workflow misses paroxysmal AFib in roughly half of cases. A 24-hour window has a low statistical chance of catching an arrhythmia that fires once a week or once a month. The right test is a 30-day ambulatory ECG monitor, sometimes called an event monitor, sometimes called a patch monitor. It is a small adhesive patch you wear on your chest for 30 consecutive days. You can shower with it. You can sleep with it. You can exercise with it. There is a button on the device. You press it whenever you feel something abnormal. The lab gets every irregular beat for 30 full days. A 30-day monitor catches the vast majority of paroxysmal AFib. A 24-hour Holter catches a fraction. Now request the second non-negotiable test, an echocardiogram. That is a painless ultrasound of your heart. No needles, no radiation. About 30 minutes lying on a table. The technician moves a wand across your chest, and the screen shows your heart in real time. The echo tells your doctor two critical things. 1. Is your left atrium enlarged? An enlarged left atrium is a structural marker of AFib risk and AFib damage. 2. Do you have any hidden valve problems? Mitral valve disease in particular is a major driver of AFib in seniors and often goes undetected for years. And then ask for the third thing, a CHADS-2 VASC score assessment. Pronounced CHADS-VASC. It is a 9-point clinical score. Each letter stands for a different stroke risk factor. Heart failure, hypertension, age, diabetes, stroke history, vascular disease, and so on. Your doctor adds up the points. The number tells you exactly how high your stroke risk is and whether you need anticoagulation. Most patients with AFib have never heard of this score. Most doctors do not volunteer it unless asked. But this single number is the most important piece of information for an AFib patient. It is the difference between needing a blood thinner or not. You deserve to know your number. Let me tell you what just happened. You walked into your appointment knowing the 3 exact things to request: a 30-day monitor, an echocardiogram, a CHADS-VASC score. Most cardiologists do not get this kind of patient. You are now that patient. So let's say you took the tests. The pulse check showed irregular gaps. The standing test produced a different rhythm. Your smartwatch flagged possible atrial fibrillation 3 times in 1 week. You're sitting there now, holding your data, thinking, what do I do? 3 actions, in this exact order. Action 1. Do not start or stop any medication on your own. Do not start aspirin thinking you are protected. For AFib, aspirin is no longer considered protective. The major cardiology guidelines now state that aspirin should not be used as the primary stroke prevention strategy in AFib. It does not work well, and it carries its own bleeding risk. If you are currently on aspirin, do not stop it without your doctor's input. If you are not on aspirin, do not start it. Wait for the proper diagnosis and the proper treatment plan. Action 2. Once AFib is confirmed, request a frank conversation about anticoagulation. The newer DOACs, direct oral anticoagulants like apixaban, rivaroxaban, and dabigatran, have largely replaced warfarin as the first-line treatment for most AFib patients. They do not require frequent blood testing. They have fewer food and drug interactions. They are easier to live with. Ask your doctor which one is right for you. Ask about the bleeding risk. Ask about the stroke risk. Use your CHADS-VASC score to make the decision rationally, not emotionally. Action 3. Get screened for the 4 conditions. The first is sleep apnea. This is the single biggest hidden driver of AFib in active seniors, and most people massively underestimate it. Untreated sleep apnea triples AFib recurrence even after successful treatment. If you snore, if you wake up tired, request a home sleep study. They are easy. They take 1 night. The second is thyroid dysfunction, especially hyperthyroidism. A simple TSH blood test catches it. Hyperthyroidism causes AFib in about 10% of cases. The third is high blood pressure. Get a home cuff. Take readings twice a day for 2 weeks. Bring the average to your doctor. The fourth is structural heart disease, the kind only the echocardiogram catches. Treating these 4 reversible drivers often reduces AFib episodes dramatically. Sometimes it reduces them to 0. That is the gift hidden inside this diagnosis. AFib is often a symptom of something else. While you wait for your appointment, 3 lifestyle moves you can start tonight. Free, no prescription needed. Number 1. Cut caffeine after 2 p.m. Coffee, tea, energy drinks, dark chocolate. Caffeine is one of the most common AFib triggers in fit seniors. Number 2. Limit alcohol to under 3 drinks per week. Alcohol is the single biggest underestimated AFib trigger. Even moderate drinkers have significantly higher AFib rates than non-drinkers. The holiday heart phenomenon is well documented. Number 3. Get to bed at a regular time. Sleep deprivation is a major AFib trigger. So is sleep fragmentation. A consistent bedtime, a dark room, no screens after 10 p.m. These are not wellness slogans. They are AFib prevention. I want to leave you with something bigger than atrial fibrillation. In seniors, the body whispers before it screams. AFib is one of the loudest whispers, but only if you know how to hear it. Brief flutters, unexplained fatigue, lightheadedness when standing. Put them next to each other and a different picture appears. They are not separate complaints. They are one conversation your heart is having with you. And your heart is saying, something is changing in my electrical system. 2 more whispers I want you to know about, because they almost always travel with AFib. The first is a vague anxiety or sense of doom. Not a panic attack, just a low hum of something is wrong that you cannot trace. Your body is picking up on the chaotic rhythm even when your conscious mind has not registered it. Many AFib patients in retrospect describe months of unexplained anxiety before their formal diagnosis. The second is a slow drop in exercise tolerance that you have been blaming on age. Last year, you ran 4 miles without thinking. This year, 3 feels hard. Last year, a hike up a familiar hill was easy. This year, you stopped twice. Not because you are declining, because your heart is fibrillating. Your engine is fine. Your wiring is the problem. I am not telling you any of this to frighten you. I'm telling you so you can listen differently. So that the next time your body whispers, you do not dismiss it. You do not blame your age. You do not assume that being fit means you are immune. Being fit does not protect you from an electrical problem. Being fit may have actually contributed to it. But being fit also means you are more likely than anyone else to catch this early, if you know what to listen for. You have a body you understand. You have decades of feedback on what normal feels like. You can detect a half second of off. That is your advantage. Use it. You hear it. You catch it. You walk into the right appointment with the right requests, and you get to the right diagnosis years before it would have caught up with you. You are not getting older. You are getting a message. If this video helped you, I would ask you to do 2 things for me. First, share this with one fit person over 60 that you know. Just one. A spouse, a sibling, a hiking partner, a friend who runs marathons. Send them the link. The fittest people are statistically the most likely to have hidden AFib and the most likely to dismiss the symptoms. You may be the reason they get screened. That is not a small thing. That is, possibly, the most important text message you will send this year. Second, subscribe to this channel, because next week I am covering the leg cramp pattern that signals critical limb ischemia. Same kind of hidden warning, different organ. The same medical system that misses AFib misses this one too. The new clinical protocols out of major academic centers have completely changed what we know about night cramps in seniors. You do not want to miss it. Before I let you go, let me give you the 1-minute version. Save this, send this, come back to it. 3 patterns. Brief flutters that come and go. Disproportionate fatigue after a stable activity. Lightheadedness when standing, especially the morning after exercise. 3 tests. The 60-second pulse check 3 times a day for 1 week. The standing test. The smartwatch ECG. 3 actions. Do not start or stop any medication on your own. Request the right diagnostic. The 30-day monitor, not the 24-hour Holter, plus an echocardiogram and a CHADS VASC score. Get screened for sleep apnea, thyroid, blood pressure, and structural heart disease. And one phrase. Write this one down right now. I want a 30-day ambulatory ECG monitor, not a 24-hour Holter. That sentence might be the most valuable thing you take away from this video, because that sentence is the one that gets you on the right path. It moves the entire workup to a 30-day map. And a 30-day map is what catches paroxysmal atrial fibrillation in time to do something about it. Take care of yourselves, listen to your bodies, trust the whispers, and I will see you next week.